This is a 49-year-old male who has a blast injury to his left foot from an exploding mole trap. Patient positioning includes a towel bump under the left hip, a well-padded tourniquet on the left thigh, a black foam ramp under the operative leg to elevate the operative site above heart level and minimize venous bleeding. TED hose and sequential compression device on the non-operative leg minimize the chance of deep venous thrombosis. And a foam pad under the non-operative leg to minimize pressure on the heel, malleoli, and proximally where the peroneal nerve is near the fibular head. Evaluation of the soft tissues shows extensive damage from the blast injury to the dorsal and plantar tissue. Evaluation of the x-rays shows residual pellets throughout the midfoot area. The lateral incision is drawn in line with the lateral malleoli and the fifth metatarsal. The dorsal incision comes across the foot just proximal to the blast injury. Medial incision in line with the medial malleolus and the first metatarsal, and the plantar incision, which is longer than the dorsal incision, goes up to the level of the blast injury. If there is no infection or tumor, sanguinate the limb and inflate the tourniquet. The skin incision should be made in a very decisive fashion to provide a pure and clean incision through skin, subcutaneous tissue, fascia, and down to bone. One should avoid feathered or beveled edges and avoid irregular cut surfaces that can lead to devitalized tissue and be a focus for non-healing or infection. The dorsal flap is elevated directly off the top of the metatarsal bones. This provides a flap of maximum and uniform thickness. The flap must be elevated back far enough to provide dorsal access to metatarsals 1 through 5 at the level of the planned bone cut, and also allows for proper contour and slope of the bone cuts. Clear the periosteum and the soft tissue off the metatarsals at the level of the planned bone cuts. This helps protect and preserve the interosseous tissue. One should cut the metatarsal bones in a way that provides the partial foot a contour and shape that is similar to the metatarsal heads in the non-amputated foot. Typically, the second metatarsal is cut first, perpendicular to its axis in the ML plane, and beveled slightly to remove more bone on the plantar surface than dorsally. The first metatarsal is cut to match the length of the second. However, it is beveled away from the second metatarsal with more bone removed medially than laterally, and more bone removed plantarly than dorsally. Metatarsals 3, 4, and 5 are cut on a line that starts at the length of the second metatarsal but slopes proximally so that metatarsals 3, 4, and 5 are progressively shorter than the second metatarsal. All cuts are designed to remove more bone laterally than medially and more bone plantarly than dorsally. Soft tissue is the primary determinant for metatarsal length. It is far better to have very short metatarsals and better padding than longer metatarsal length and scarred, thin, or damaged soft tissue coverage. The metatarsals are dissected up and off the plantar flap in a proximal to distal direction. This maximally preserves the interosseous tissue. The sesamoids may make this dissection a bit difficult on the first metatarsal. Next, the second metatarsal is dissected from proximal to distal, again preserving the interosseous tissue. Likewise, the third, fourth, and fifth metatarsals are dissected from proximal to distal. The tissue in the blast injury is more severely damaged than on the medial and lateral borders of the foot. The dissection continues between the first metatarsal and the sesamoids. Initially, the sesamoids are left with the plantar flap and plantar tissue. The dissection of the plantar flap is completed, removing the metatarsals and the residual forefoot. Care is taken to leave the plantar flap as smooth, thick, and healthy as possible. Trial positioning shows how the plantar flap folds up and over the metatarsals. Severely damaged and non-viable tissue in the blast zone must be removed. Care is taken to leave the flap as thick as possible, but again, the damaged and non-viable tissue must be removed. Attention is returned to the contour and shape of the metatarsals. A rongeur is used to trim the plantar surface and remove any small fragments of bone. This shows simulation of the foot as it matches the ground. The oscillating saw is used to remove the dorsal contours and any sharp edges. And the rasp provides a final smooth surface to the metatarsals. In cases with residual pellets or shrapnel, C-arm imaging is used to identify and remove any remaining foreign bodies. The tourniquet is let down and initial hemostasis is obtained with pressure. Irrigation solution is used to irrigate the tissues and remove any residual bone fragments. Any small bleeding vessels can be clamped and ligated. Electrocautery is also used to obtain hemostasis. A small vein is ligated with absorbable suture. Further hemostasis is obtained using electrocautery. The common digital nerves in the plantar flap should be identified, drawn down, and divided so that they retract away from areas of pressure and scar. These nerves can sometimes be very difficult to identify. A balance must be made between identifying the nerves and excessive dissection and trauma to the posterior flap. In blast injuries, some of these nerves may simply no longer be present or identifiable. Intraoperative imaging shows the contour of the metatarsals on the lateral and AP views. Tissue in the zone of injury is further debrided. The foot and wounds are further irrigated with saline solution. At this point, the sesamoids are identified and carefully dissected away from the plantar flap. The tendons are relatively avascular. These are drawn down, divided, and allowed to retract. A hemovac drain is placed, exiting up and out the dorsolateral tissue. The drain is cut and positioned under the metatarsals. The plantar flap is wider and longer than the dorsal flap, so the closure must be done to equally divide and position the two flaps. The extra width in the plantar flap is equally divided and spread out over the entire incision, the divide and conquer method of closure. One key is to place the first suture to oppose the center of the plantar flap and the center of the dorsal flap. The fascia on the plantar flap is sewn to the periosteum that was elevated up and off the dorsal surface of the metatarsals. The second deep suture centers the lateral one-half of the plantar flap to the lateral one-half of the dorsal flap. In midfoot amputations, the length of the plantar and dorsal flaps are not equal. The divide and conquer method of closure distributes the excess tissue evenly across the entire length of the incision. The third deep suture centers the remaining portion of the lateral flap with the remaining portion of the lateral dorsal flap. The fourth deep suture begins to center the remaining medial plantar flap to the remaining medial dorsal flap. In a similar fashion, the fifth suture centers the central medial plantar to the central medial dorsal flap. The subcutaneous closure is best done with horizontal sutures to again distribute the extra tissue or width in the plantar flap against the dorsal flap. This illustrates where the extra tissue on the plantar flap on the lateral side is again divided in half and brought up to the dorsal flap. The skin is closed with a 3/0 nylon suture placed through the dorsal flap and through the high points on the plantar flap. After closure and apposition of the tissues, attention is then turned to the Achilles tendon and prevention of equinus. We are planning an Achilles tendon lengthening using the 3 hemitendon section technique. This schematic shows the 3 hemitendon cuts and how they open to provide lengthening. The distal cut cuts through the medial half of the tendon. The central cut cuts through the lateral half of the tendon. And the proximal cut cuts through the medial half of the tendon. The foot is gently stretched into dorsiflexion to lengthen the tendon and provide the increased dorsiflexion. The small incisions in the back are closed with simple steri strips. Post-operative dressing starts with non-stick gauze. Regular gauze is opened up and laid individually to avoid one large lump of gauze. Gauze is also placed over the Achilles tendon and more gauze padding over the incision site. Fluff gauze is placed posteriorly and dorsally over the incision site. Curlex roll is then added to hold the gauze in place and contour the gauze. Care is taken to keep either gauze or cotton padding between the skin and the drain site. Drapes and the tourniquet are removed. Web roll cotton padding is placed over the gauze and again is placed between the leg and the drain to allow the drain to slide out from underneath the rigid dressing. More rubberal cotton padding is applied to protect the limb, prevent pressure sores, and help control and minimize edema. Rest-on foam padding is added to protect the Achilles tendon area, the plantar surface of the foot, the malleoli. Cotton cast padding strips are also added for added protection. Five-ply plaster slabs are applied to the lateral, medial, and posterior surfaces of the foot. The plaster splints are held in place with bias cut stockinette. The rigid dressing is carefully molded on a pillow to keep the foot into slight dorsiflexion and avoid pressure points in the plaster. Tape is used to secure the bias cut stockinette. A mold is placed in the arch area to keep the foot up in dorsiflexion. 7-month follow-up shows the range of motion in the ankle and subtalar joints. The patient does have some limitations in plantar flexion and dorsiflexion compared to the non-amputated side. He is able to walk limited distances in a barefoot fashion. He still has some hypersensitivity and pain over the distal end of the amputation site. The first postoperative prosthetic device is fashioned in the style of a Charcot restraint orthotic walker. This partial foot prosthesis looks a bit like a Herman Munster boot. It is designed to totally protect the foot and lock out the ankle motion during early ambulation. On the inner surface, it is lined with P-Lite foam. Foam can be added to take up for the volume loss of the foot. The swelling following partial foot amputation necessitates the use of this type of device in the first 4 to 8 months. It is rare that a partial foot amputation will fit into a smaller device and into a more regular shoe until months 6 to 8.